the initial modality of choice, or if patient coming with head trauma, how you are going to investigate that patient? Yes, Yeshabab. CT scan. So CT scan is the initial modality of choice, and most of the time it is the best modality of choice. Okay. In case of, for example, there is chest injury, what should be the best modality? Or starting with initial modality, X-ray will be the initial or the Mumtaz? You can use your microphone, please. Okay, initial. Okay, good. And what should be the Mumtaz for chest trauma?
Will be the ultrasound, doctor.
For chest,
MRI, I think.
anyone else? Anyone else? CT scan is the best modality for assessment of chest trauma. Okay. Ultrasound, can ultrasound be performed for chest? Can ultrasound be performed for chest? Why, Salman? What is the reason? You are right, but what is the reason? Lesh, Waja.
Doctor, maybe because of most of the chest is air.
Very good. And the ultrasound waves cannot travel through air. Yes, if you remember, I told you the ultrasound waves have a limitation in traveling through air. If the lungs are diseased, okay, for example, there is collection of fluid in the pleural cavity. Okay, if you want to see the pleural effusion, then you can visualize. Then we can use the ultrasound. If there is consolidation or collapse in the lungs, okay, then you can visualize the lungs. Otherwise, if there is air in the lungs, you cannot visualize the lungs with ultrasound. Do you understand me?
Yes, doctor. I didn't understand.
Okay. For abdominal trauma, yes, how will you investigate? Ultrasound. Okay. Do you know what is the special name of the ultrasound which is performed in blunt abdominal trauma patients? You must have studied in surgery. Anyone? What is the name of ultrasound we perform in patients who are coming to emergency for blunt abdominal trauma patients? Yes, Mohammad Khalaf, Rayan Abdulaziz, Abdullah Ali, Sukar Khalaf, Rayan Ahmed, Saif Sari, Jara Talal, Yusuf, Saud, anyone? Okay, that the name of the ultrasound is fast ultrasound. Have you heard of fast ultrasound before? No? Yes. Okay. Okay. So, what is this fast ultrasound, Yusuf? What is the meaning of fast ultrasound? Very good. Focus assessment. Okay, we perform focus assessment of the abdomen. Okay, to look for any bleeding within the abdomen on a specific area. Uh, Wait on a minute. Okay. So moving on to next slides. In CNS trauma, radiography is valuable in assessment of skull fractures. However, CT scan is far more superior than radiography. Okay, so this we have discussed before also. Okay, so after skull trauma, okay, CNS trauma, what are the possibilities? Patient can develop fracture, patient can develop subarachnoid hemorrhage, subdural hematoma, epidural hematoma, intraparenchymal hemorrhages, diffuse axonal injury, cerebral contusions, or intraventricular hemorrhage. These are new things you must be hearing: diffuse axonal injury and cerebral contusions. Okay, cerebral contusions is the most commonest injury which happens after head trauma. Okay, and diffuse axonal injury, I will show you what is diffuse axonal injury. Diffuse axonal injury, it has a very poor prognosis. Okay, whenever it occurs. Okay, skull fractures, you can see that in these images. Okay, you can clearly visualize this is a bone window. Okay, of a brain. Okay, you can see the depressed fracture here. You can see the linear fracture of the skull. Okay. Subarachnoid hemorrhage. Trauma is the most commonest cause, most common location over cerebral convexity in cerebral trauma. CT scan can be performed, and what you will see hyperdensity in sulci or basal cisterns. Yes, who will describe this image? Yes, Shashaba.
Doctor, I think it is a CT scan for the skull. There is a fracture in the bone, the skull.
What about the brain?
Doctor, there is a hyperdensity in the center.
Hyperdensity in the sulcus. And what is this ankabut shape? Yes, what is this ankabut shape? Yes.
The gray matter, Doctor.
No, I'm talking about this ankabut shape. This is the
I
basal
got you,
cistern.
Doctor.
This is the basal cistern. Okay, these are basal cistern. At the base of the brain, I told you that at the base of the brain there are CSF pockets. Okay, normally this ankabut is aswad. Okay, here it is abyad. Why? Because of the collection of because of the hemorrhage within the basal cisterns. Did you get me? Understand my point? Okay, again you can
Yeah,
see
we
this.
get it, Doctor.
Yes, this is again ankabut shape. Okay, these are basal cistern. Okay, What are basal cisterns? Basal cisterns are at the base of the brain. There are basically CSF pockets. Okay, these pockets are normally, because they contain CSF, so they will be black. But here they are abiyad, okay, because of hemorrhage. Okay, subdural hematoma. Okay, who will tell me what is the what are the findings in subdural hematoma? On CT scan, what are the findings in subdural hematoma?
I think there will be hyperdensity.
Hyperdensity where? मतलब, what should be the shape?
Concave shape, doctor, on the brain, in the CT scan.
Yes. This is subdural hematoma. So what is this shape?
Concave, doctor, hyperdensity.
You say
Convex,
concave,
convex.
not concave or convex. What is the name? Exact name?
Crescent shape, doctor.
Crescent shape. Okay, hilal shape. If you see here, this is hilal shape. Okay, but in some areas it may be irregular also. Like here, it is biconvex here, but that doesn't mean this is epidural hematoma. In some part, okay, it may be irregular subdural hematoma, but in some part it will always be crescent shape. Okay, and you can also visualize that because it is bounded by the dura mater, the blood is not going on the opposite side, it is going into the falx. Okay, epidural this is epidural hematoma. You can see that this is a lens shape hyperdensity with associated fracture, and soft tissue hemorrhage is also there. Okay, so this is epidural hematoma. Again, epidural hematoma. Okay, diffuse axonal injury, as I told you that it occurs due to shear injuries. There is deformation and tearing of the axons. It is most common cause of significant morbidity. Okay, CT scan of the brain is on CT scan. You will find ill-defined areas of high density in characteristic locations. Okay, where characteristic location, we know that axons are present in the white matter. Okay, nerve fibers are present in the white matter. Yes. So we will see the hemorrhages. If we see after trauma, head trauma, if in CT scan, if we find hemorrhages in the area of the white matter, they are due to the diffuse axonal injuries. Okay. So the most common areas which are involved are subcortical white matter, posterior limb of internal capsule, corpus callosum, and dorsolateral midbrain. Okay, this is the posterior limb of internal capsule. This is the area of posterior limb of internal capsule. Okay, this is corpus callosum. There is hemorrhage within the corpus callosum because corpus callosum basically are nerve fibers which are going from one cerebral hemisphere to the other cerebral hemisphere. They go above the lateral ventricles. You can see this is in between and above the lateral ventricles. Okay, cerebral contusions is the most common primary intraaxial injury. Occurs when the brain impacts on the osseous ridge or a dural fold. Okay, CT scan of the brain plane will show ill-defined hypodense areas with mixed hyperdense foci of hemorrhages. along the gyral crest. Okay, the cerebral contusions are seen on the gyral crest. Okay, the gyri of the brain. Okay, if you see hemorrhages, these are cerebral contusions. Okay, the most common sites include the temporal lobe, anterior lip, inferior surface, frontal lobe, anterior pole, and inferior surface. Okay, why they are more common here? Because they are more near to the osseous bony ridges. Okay, dorsolateral midbrain and inferior cerebellum. Okay, you can see this is the inferior surface of the frontal lobe. Okay, and these hemorrhages are present in the gyral crests. Okay, you can see again inferior surface of the temporal lobe. This is the temporal lobe. Okay, this is the anterior and lateral surface of the basically the frontal lobe. Intraventricular hemorrhages associated with diffuse axonal injury, deep gray matter injury, and brainstem contusions. CT scan will show hyperdense material in the ventricles, like this. This is the hyperdense material within the ventricles. Okay, facial trauma. Okay, what to order is we can perform plain X-ray of the skull. We can perform CT scan. CT scan is the ideal modality of choice for assessment of the facial bone trauma. Okay, especially the bone window, axial, and coronal with 3D reconstruction. History of trauma to the face, disfigurement, and severe facial contusions. This is X-ray. You can see on X-ray, you can clearly visualize the fracture of the mandible. Okay, and this is the also X-ray of the face. This is a special view which is known as PNS, paranasal sinuses view, or Waters view. Okay, this is a special X-ray done for paranasal sinuses. You can see this is the maxillary sinus. Okay, and this is frontal sinus. Okay, and this is the orbit. Okay, you can see the inferior wall of the orbit is intact here on the right side, but here there is a fracture. Okay, this X-ray is specially performed to visualize the fractures of the facial bones, especially the zygomatic bone and the orbital bones. Okay, orbital trauma, spine. Okay, in spine. Okay, we can perform X-ray, we can perform CT scan and MRI if there is suspected cord injury. Okay, otherwise, plain X-ray or CT scan can be performed. You can see this is the base of the basically C2 fracture. Okay, this is the odontoid process, and this is the base of the odontoid process. There is fracture here. This is CT scan, and again on X-ray you can see that there is fracture of the base of the odontoid. Okay, this is CT scan, bone window. Okay, this is MRI showing that there is injury to the cord also. This is the spinal cord. Okay, chest trauma. After chest trauma, patient can develop rib fractures, hemothorax, pneumothorax, pneumomediastinum, pulmonary contusion, laceration, hematoma, esophageal injury, diaphragmatic injury. As I told you that if the patient is not very serious, okay, we can perform X-ray as well as CT scan of the chest. CT scan of the chest is the ideal modality of choice for the assessment of the chest injury. Okay, because it will give you information, more information as compared to the chest X-ray, and you can miss fractures or subtle pathologies or subtle findings on chest X-ray, but you cannot miss findings on CT scan. Like here, there is a fracture here, but it can be easily missed. Okay, but when you perform CT scan, you can clearly visualize there is fracture of the rib. Okay, this is chest X-ray showing and basically there is a very severe injury on right side. Okay, and you can see there are multiple fractures in multiple ribs, and the fractures are at more than two parts. Okay, this is a special type of fracture which is called flail chest. um, you can see here, after trauma, you can see that there is trauma to the mediastinum, there is collection of air, there is basically trauma to the trachea, and there is leakage of air into the mediastinum, causing pneumomediastinum. This is lung contusion. Okay, the lung, you can see there is increased density in the lung due to the lung hemorrhage or lung contusion. Okay, now the most important thing, the abdominal trauma. As we discuss, okay, if a patient comes with history of blunt abdominal trauma, okay, the best initial modality for assessment is fast ultrasound. Okay, and what is fast ultrasound? Okay, first I will tell you what is fast ultrasound. It is focus assessment with sonography for trauma patient. What is the meaning of focus assessment? Okay, we will focus in some areas, okay, uh, which are the dependent areas, okay, where the blood will collect after injury to any solid organ. And what are the most common solid organs which are injured in blunt abdominal trauma? Spleen is the most commonest. Second most commonest is liver. Okay, and that's why we perform basically four views in fast ultrasound. Okay, this is the first view, which is called subcostal view. Okay, and we perform the ultrasound in the epigastric region, and just above the epigastrium there is heart. Okay, and you can see if there is any injury to the heart, it can be easily assessed with the help of this view. Okay, you can see that this is the right atrium, this is right ventricle, this is left ventricle, this is left atrium, and surrounding, this is the myocardium, and surrounding the myocardium there is collection of fluid. Okay, this collection of fluid is due to hemorrhage in the pericardial space. Okay, so basically this is a very severe injury. Patient may be sitting comfortably, and suddenly the patient will collapse. Okay, because of the cardiac tamponade. Okay, so this patient should be managed very aggressively and instantly. Okay, so this is the first view we perform in basically the fast ultrasound. The second view is the right upper quadrant view. Okay, you can see that first of all, as I told you, that second most commonest organ injured is the liver. Okay, so with this view we can assess the liver also, and between the liver and the kidney, this is the Morrison pouch. Okay, this black area. Okay, you can see there is fluid here, collection of fluid here, because this is again the dependent portion, so the blood will collect here, so we can easily detect the blood in this area. And the second view is the left upper quadrant view. Okay, and why left upper quadrant? Because again, the most common injured organ is the spleen. You can assess the spleen as well as the space between the kidney, left kidney, and the spleen will be, again, it will be a dependent portion, and any collection of blood will also collect here also, so we can assess whether there is intraperitoneal hemorrhage or no. The third area is the most dependent portion in the pelvis. Okay, in the suprapubic area we will perform the ultrasound. The blood, if there is any minimal blood, it will collect in the area between the bladder and the rectum. Okay, this is called the rectovesical pouch. Okay, or the pouch of Douglas. Okay, and you can clearly visualize there is no fluid here, but in this image you can see this is urinary bladder, and this is rectum. Between the bladder and the rectum there is collection of the fluid, okay, and it confirms that there is intraperitoneal hemorrhage. uh, this is the chart showing how will you assess a blunt abdominal trauma patient in emergency. Okay, patient coming to ER, if the patient is hemodynamically stable, okay, we if the patient is hemodynamically stable, we will perform the fast ultrasound. If it is positive, then we will shift the patient to CT scan department for grading of the visceral injury. Okay, and if it is negative, fast ultrasound is negative and the patient is stable, we can send the patient to the ward and perform clinical observation, and we can repeat fast ultrasound or CT scan after some time. But in cases where patient is hemodynamically unstable, okay, we will perform the fast ultrasound. Why? The reason is that even the patient is unstable, that means the blood pressure is unstable, the heart rate is very high, but still we can perform the ultrasound on the patient bedside. Okay, this is the biggest advantage of ultrasound. Okay, and after performing fast ultrasound, if the fast ultrasound is positive, okay, then we have to shift the patient for laparotomy, not for CT scan, because the patient is unstable. Okay, we have to directly take the patient to OR, operation theater. Okay, and we can open up the abdomen and we can visualize that from where there is the blood is leaking, or where is the hemorrhage coming from. But if the fast ultrasound is negative and the patient is again hemodynamically unstable, then we will look for other sites of blood loss. Like there may be CNS hemorrhage, there may be hemorrhage in the chest, hemothorax. Okay, so we will look for other causes. Okay, and after we can consider a repeat ultrasound fast or diagnostic peritoneal lavage also. CT scan, as I told you, we use CT scan abdomen for grading of the visceral injury. Like here, you can see this is a splenic trauma grading system. You can see there is grade 1, grade 2, grade 3, grade 4. Grade 1 is simple, small laceration. Grade 2 is bigger laceration. And what is the advantage of this grading is that it can help you in management of the patient. If there is grade 1 and grade 2 injury, we can manage conservatively. Okay, and if there is grade 3, grade 4 injury, we can perform surgery. Okay, because in grade 3 injury, fracture extending to the hilum of the spleen. Okay, because at the hilum the main blood vessels are coming, so it is a very severe injury. And grade 4 is shattered spleen, multiple lacerations in the spleen. So these both can be managed with basically surgery. Okay, and grade 1, so this is the advantage of CT scan. You can perform grading, and grading will help you in further management of the patient. Clear here, Shabab? Any questions? Okay, this is the laceration you can see. Okay, and remember this laceration will always appear as hypodense line. Okay, a laceration will appear as hypodense linear line, and you can see the collection of blood around the kidney. This is the subcapsular hematoma. Within the capsule of the kidney, okay, there is collection of the blood. This is subcapsular hematoma. Okay. And after contrast, the laceration will always appear as hypo-enhancing linear line. Okay. This is the basically urethral trauma. Okay, urethral trauma can be assessed with the help of micturating cystourethrogram. This is a MCUG examination, okay, for urethra. Okay, you can see the different parts of the urethra. This is prostatic urethra. This is the membranous urethra. This is bulbar urethra. This is the penile urethra. Okay, there is laceration in the area of the membranous urethra. This is the most common site in pelvic fractures for urethral injury. Okay, you can see there is extravision of the contrast here. This examination is called micturating cystourethrogram. Okay, for bone trauma, okay, we always start with X-ray, and CT scan can be performed for patients who have complex fractures, complicated fractures, or complex fractures. Okay, and especially in areas where the bones are overlapping, like face, skull. Okay, they X-ray is not very helpful in fractures of face and skull. So in these areas, we can perform CT scan. MRI and ultrasound are mainly done to see the soft tissue injuries. To assess the soft tissue injuries, we always perform MRI or ultrasound. Yes. Any questions, Yeshaba?